We'll just give people a couple more minutes. If you could just let me know in the chat if you can see the slides okay and hear me okay, that would be great. Right, we'll get started just because it is 7 and I know a lot of you are still on Christmas holiday, so probably don't want to spend too long. So hi, my name's Chrissie. I'm an F1. I'm currently working in the Trent Deanery. Today we're going to be looking over some paediatric respiratory conditions, some of the key ones for the UK MLA exam. I'll have some questions going sort of throughout. It'd be great if you could interact, just answer in the chat with your answers. I've got a couple of polls as well. Just make it a bit more interactive, and there'll be a chance for questions at the end. I've also put my email address at the end of the presentation as well, and I'm more than happy for you to message me any questions you have, and I'll either answer them best I can or find someone that can answer for me. Okay, so just a quick look at what we're going to cover. I plan to try and get through quite a lot, so it will be a bit of a whistle-stop tour, hopefully giving you a bit more of that high yield revision that you've probably joined this call for. My advice would be to sort of make notes as you go along, but don't stress too much because the slides will be uploaded. You'll be able to watch the recording back, so you can look back at anything you're not sure about. I'll try and signpost you to anywhere for some good sort of advice along the way if I can. So I've just included this picture. It's just a very quick look at, without going into too much detail, a paediatric upper airway anatomy, especially in babies and sort of your infants. It's just keeping in the back of your mind when we're talking about all of these conditions, some of the things that make a paediatric airway different to an adult airway. So thinking about how sort of, especially relative to their size, the tongue is much larger. They have these narrow nostrils as well, which when we're speaking about breathing can make quite a big difference. So first, we're going to look at bronchiolitis. So one of the most important things, I'll cover it in detail with this condition, and then with the others won't go into it, is thinking about sort of your features that you want to ascertain when you take a history. So obviously you have your paediatric history taken, which if you want a session on at another point, let me know and I can look at including that as well. But really what we're talking about here is that focused history taking. So you're wanting to ascertain sort of any symptoms that happened beforehand, so any coryzal symptoms. Have they had a runny nose? Have they had a bit of a cough? Or is this something that's newly come on today and before today they were not unwell? You're also wanting to look for those signs of respiratory distress, and we'll go into those a bit more later. Obviously, this is very similar, all of these so far, to adults as well, with the dyspnea and tachypnea as well. But more specific to paediatrics is the poor feeding. That's a good sign for you as a clinician of how unwell a child is how is their feeding. And the best person to ask is the parent or carer. Are they taking less bottles than normal? Do they normally breastfeed and they've not been latching well, but normally they're fine and have no trouble? Are they a toddler that's normally going around grabbing food constantly and always eating, and now they've got no appetite? These are some of the things that you want to ascertain. Okay, so the first poll, which I hope will work, if I start this now, we're looking at what is the most common cause of bronchiolitis. So if you just submit your answers to that, I'll give you a minute. Okay. Just give a couple more seconds. Okay, perfect. So we've had 95% of you have said RSV, and that would be correct. If you said any of the others, they are all causes, but the most common cause is RSV. So just worth being aware of that for your exam, but it could also be caused by any of the others as well. And now's when I need you to sort of message in the chat if you can. What are some signs of respiratory distress that we might be looking for, either in an infant, a baby, child, adolescent? I'll give you 2 minutes if you type in. Perfect. Yeah, nasal flaring, grunting, head bobbing. Yep. Perfect. Yeah. So, retraction, wheeze. Yeah, shallow, rapid breathing. Abdominal breathing. Yes. Perfect. Yeah. Great. Perfect. So I've split these into sort of going from the more mild ones to the more severe. That's not to say that you wouldn't be worried if you saw any of the things that you've suggested. So starting with sort of your more mild ones, you might have a bit of abdominal breathing. The reason why these first ones are mild is because it could just be the normal way of sort of overcoming some difficulty. For example, if you were to go outside and run down to the end of your road, you might be working harder to breathe, but it doesn't mean that you're actually in any kind of real distress or real danger of losing your airway. You're just working a bit harder to overcome the issue that's been caused. Tracheal tug, it's worth knowing that the older the baby, that's the more serious that is as a sign. So in very, very little babies, or very young babies, I should say, neonates, some tracheal tug can be more of a mild sign. Nasal flaring and intercostal recession are sort of your moderate signs. And then your more severe is the head bobbing and grunting. I wouldn't worry too much about being able to sort of classify them, because realistically at this stage, and even when you're first working, you're more wanting to say, is this a patient that could be in respiratory distress or not? So just to be aware of those. Okay, so here is just a slide I've put together that will help you to think about breathing in infants. So this is actually how it's taught in APLS. So don't worry about memorizing it or anything like that, because it's not on the UKMLA content, but it can help with understanding things a bit better, which in turn might help with the UKMLA. So in APLS, we divide respiratory distress into effort, efficacy, and effect, where effort is the rate and work that the child is doing. Efficacy is the oxygenation and CO2 removal, cyanosis. Effect is, for example, tachycardia, poor perfusion. There might be mottling of the skin, reduced GCS, etc. I think, maybe not everyone thinks, I think this is the best way to think about breathing in babies. And you're asking yourself 3 things. Are they working hard or not? Is it this effective or not? And what is the systemic effect of the effort? So we'll put that into an example. So you may have baby 1 who's got some intercostal recession. You think they're working a bit hard to breathe. It looks like it might be a bit difficult for them, but it's effective. They're maintaining their saturations really well, and the baby is alert throughout, no apnea episodes. But you could have baby 2, again, has some intercostal recession, that's working quite hard, but it's not effective. And this baby has poor saturations and a reduced GCS. the difference in these is they have the same effort that they're putting in, but it's the efficacy and effect that's different. So it's remembering to look at all of these things. So in this scenario, chances are that actually baby 2 is in such severe distress that they're so worn out, they've not got the effort that they can put in. So actually all that they can manage is working a bit harder with some intercostal recession. Right, so the important thing, when would you admit someone to hospital or child to hospital? So there's all sorts of exact numbers you can look at. As with anything, sort of having an idea of rough numbers is great for exams, but in practice, a lot of it is done based on clinical judgment. If there's episodes of apneas, then absolutely admit them. Ballpark figures, oxygen saturations less than 90 if the baby or child is over 6 weeks. Or if they are under 6 weeks, then you're looking at less than 92%. Or if they have any underlying health conditions. In terms of oral intake, that's also really important. You're looking to around 50 to 70% of normal intake. If you think about sort of when you're unwell, you might not feel like eating as much, but normally, unless you're very, very unwell, you're still able to have some water. You think about a baby, they're getting all of their nutrition sort of from either their formula or their breast milk, so they've not got that water intake as well. So we do become very worried very quickly if they are not getting their oral intake. And again, moderate respiratory distress. So based on those symptoms we looked at a few slides ago, but if you are somewhere like in a GP and you're not really sure, it is always better to err on the side of caution. So some management for bronchiolitis. The main things is think about sort of similar in adult medicine, your A to E approach, you're treating as you find things. A to E will tell you sort of what you're trying to do. You might see that they need oxygen, so you give oxygen. Nasogastric fluids can be used if they don't have good intake. Orogastric tubes can be used. This would sort of be found in the neonatal unit mostly. It's when babies aren't able to suck properly. IV fluids may be required. You can use high flow or non-invasive ventilation if you think some baby is at risk of respiratory failure. And upper airway suctioning, you'll use this in apneas as you're not sure, you can't be sure, you need to make sure the airway is clear. If they're in distress or their feeding is impeded by upper airway secretions. So in the comments now, so we've got a baby with, we think this is bronchiolitis. When might we consider pneumonia as differential? What might suggest that this is pneumonia and not a bronchiolitis? Let's give you a couple of minutes. I'll take that as people are either, oh, there's one there. Yeah, fever, perfect. So 2 things really, high fever. Yeah, duration as well, that's very true. Actually, you might be suspecting it. It would probably be on your differential list, but high fever, definitely. And the other one that I've put down is persistently focal crackles. So it's quite hard with babies and young children, but if you're able to listen and you can hear that it's very much localized to one area, you might be thinking that there's some consolidation there and that's what is causing that. So for the next one, again, if you can answer in the chat, that would be great. What would make you think about viral induced wheeze? So if anyone got any answers? Anything you can think of when we speak about viral induced wheeze? Yeah, expiratory wheeze sound after a recent viral illness. Wheeze over stridor. Perfect. So one thing, so this top point, persistent wheeze without crackles, I've put that there as a bit of a warning. I've seen this written in some textbooks. Just don't fall into the trap of this is the only thing that is sort of makes the difference, because some bronchi babies may sound wheezy and vice versa. So just be a bit aware of that. Yeah, I've also seen older infant over 1. Great. So the main difference is the pathophysiology. So you're looking at bronchiolitis is a slow prodrome over days. Viral induced wheeze, as you've correctly said, is usually above 12 months old, usually a shorter illness. And the work that they're putting in to their breathing is out of keep with the rest of their illness. And you've got that prolonged expiratory phase with the wheeze, and they have a bronchospasm, which is not something you can necessarily see or ascertain from the history, but you get that impression. So the idea of the work they're putting in is out of keeping with the rest of their illness. Is they might have something that to another child is quite mild. They might have had just a little bit of a viral infection, a bit of a cold, but actually they're really struggling with their breathing. You wouldn't expect a child to be wheezing just because they've got a bit of a cold. Between 9 and 24 months of age, there's a mix of pathology, and almost all under 9 months will be bronchiolitis, and almost all above 24 months will be viral induced wheeze. But in the middle, there is a real mix. And again, illnesses don't read textbooks, so that's not always the case, but that's pretty much how it follows. And especially with your SBA questions for exams, sort of those age ranges can really help you to find what the correct answer might be. Moves us on to our next sort of point, which is multi-trigger wheeze. You might have heard of this as early onset asthma. Multi-trigger wheeze is kind of the preferred terminology now, but you'll probably hear a bit of both. It doesn't matter too much. We are trying to move towards multi-trigger wheeze though. The most important feature is there are interval symptoms, and they'll wheeze more than just when they have a cold. So they'll wheeze at night, they'll wheeze because the house is a bit dusty, they'll wheeze because they went to a friend's house that had a dog and they might have a bit of an allergy. If it's someone with viral wheeze, so recurrent viral wheezes, they'll get their cold, they'll look unwell, and then they'll get better. Whereas your multi-trigger wheeze, they don't have this pattern of sort of getting unwell and then getting better. They sort of have these on and off phases of wheezing. And then just a note there at the bottom, multi-trigger wheeze are more likely to develop asthma as they grow up. Viral induced wheeze, they tend to grow out of it by age 5. But again, just be careful. There'll always be some crossover, that you'll always have some that don't follow the rule. So here is just a bit of a memory tool. It's not that sort of straightforward, but a bit of a memory tool for viral induced wheeze. This is kind of how the illness will go. So you encounter a virus, you get a bit of inflammation and edema, the airway will swell, the smooth muscle will then constrict, and then that airflow through a narrowed airway is what causes the wheeze. That causes the restricted ventilation, and then that causes the respiratory distress. So now we're going to move on and we're going to look at acute asthma. Does anyone know, and again, put any ideas in the chat, how we classify asthma, or some of the things we might be looking at when we're classifying acute asthma? Yeah, great. These are all correct, all things that we'll be looking at. Ability to complete a sentence, great. Triggers, perfect. So acute asthma, we're looking at moderate, severe, life-threatening. Again, different trusts, different places, different textbooks may have a mild, they may have moderate, they may have severe. Most now will use moderate, severe, and life-threatening. You again have all these numbers that you could memorize if you want to, but as long as you can roughly know where something fits in. So the sort of the crude test and the easiest way is if you're talking to a child and they're able to speak back to you, they've got normal speech, you'd probably say they've got moderate asthma. They're able to complete the sentence and they're okay. If they're needing to take a breath mid-sentence, then we'd likely classify this as severe, especially when coupled with sort of an increased respiratory rate or their saturations have dropped. Life-threatening, the most important one is that silent chest. That's a scary, scary sign. That is sort of you immediately need to get as many people in to help you as possible. That's something you don't ever want to be seeing. Okay. So key management of acute asthma, and I've put in brackets, or viral induced wheeze, follows kind of similar thing. So you're looking at your 4 steps of supplementary oxygen. Again, back to this whole A to E idea, sort of treat as you find. They're struggling with their saturations, give them some oxygen. Bronchodilators, we've spoken about the airways sort of constricting, so we want to try and open those up, make it a bit easier for them to breathe. And then very similar to in adults, we're looking at steroids next, so oral prednisolone, IV hydrocortisone, IV steroids is something you'd be definitely looking at a senior to as advice on whether that's something that needs to be started. Antibiotics, depending on the cause. And then bronchodilators, again, same way as in adults, which you probably know, they're stepped up as they're required as well. So I think I've got another poll for you. There we go. So this one is looking at when can we think about discharging a patient who was admitted with acute asthma. Okay, so we have a bit of a mix of answers there. That's okay. It's either something you know and have come across or you don't. So what we say, or the guidance, is when on no more than 6 puffs, 4 hourly of salbutamol. And that may seem like quite a lot, but actually your sort of most important things when discharging a patient is sort of remembering that from acute asthma, it can take a while to recover. So actually 6 puffs, 4 hourly of salbutamol is not a lot compared to when they were having back-to-back nebulized salbutamol, maybe IV, steroids, etc., etc. And actually, while same as with an adult, while a child is in hospital, they are more susceptible to hospital-acquired infections as well and further complications. When you are looking to discharge someone, you need to make sure you safety net. Always safety net, most important thing. What should the parent or carer be looking out for? When should they bring them back? What should make them phone an ambulance? What should make them go to the GP? What should they do if they get home and they don't know sort of what's going on, etc. Individualized asthma plans. The way sort of asthma is going now, everyone should be having individualized asthma plans. These should start from even in adults with GPs producing asthma plans as well at annual reviews. but also these should be reviewed with every acute admission as well to check that they're still relevant, if any changes have been made. Encourage parents to stick it on their fridge, make sure they've got a copy on their phone. If the child's at school, make sure that the school have a copy so they know what to do if they think that the child is having an asthma attack. And then most importantly, when you're the one discharging a patient, are you happy that the parent or carer understand enough about the child's asthma, when to get help and how they'll manage at home to be happy to discharge them home? If you're not, and you're not sure the parent understands the severity, you're not sure they're going to be able to safely administer the salbutamol yet, or they need a bit more asthma inhaler training, keep the patient in. Just a little note as well, some of you may come across on placement or when you're working, or maybe even some things you read, reducing regimes. So children that were admitted with an acute asthma attack used to be discharged on a reducing regime. So on their last day of admission, they might have been on 6 puffs 4 hourly of salbutamol. Their reducing regime will tell the parent that on day 1, they should now be on 4 puffs 4 hourly, and you'll do that for 2 days, and then you'll do 2 puffs 4 hourly, and so on and so forth. We are moving away from this and actually trying to encourage limited salbutamol use, and trying to encourage regular assessment of a child instead. And with that comes more sort of education for the patient if the child is old enough, but the parent. Just to answer the question in the chat, yeah, it should always be spacers in paediatrics, and actually even in adults now, they are trying to push for spacers to be used more, as even in the best inhaler technique, a spacer is just more effective. So when looking at chronic asthma instead, the most sort of important things are things you've already pointed out about asthma. It might be episodic. You're seeing these intermittent exacerbations, it's happening at night. It's happening when they have hay fever in the summer. You're seeing the typical triggers of the pet fur and dust. That should say history of other atopic conditions. Be that in the family or in the individual themselves? Have they sort of got the eczema, asthma, hay fever triad? They have this bilateral widespread wheeze. It's not sort of located in one area. You can hear it throughout the chest. Often you don't even need to listen to the chest. You can just hear them from the end of the bed wheezing away. Symptoms will improve with bronchodilators. With some children, that takes longer to find sort of the level that they need, but in general, asthma improves with bronchodilators. We know that works well. It's just finding sort of the best regime for each patient. So we'll move on, looking at croup. So what you need to remember here is this is an upper respiratory tract infection, and it's causing edema in the larynx. And this is typical in your 6-month to 2-year-old children. For your exams, be aware of parainfluenza as the cause of croup. There are, as with everything, multiple causes, but that is the one that they'll ask about a lot. It usually responds well to dexamethasone treatment. Usually only need a single dose and they're better, and there are some of your other causes there. In the chat again, if you could put any ideas you have about how does croup classically present, what might a child present with that's making you think of this as the diagnosis? There we go, spot on. Barking cough. So presentation is this barking cough. We're actually finding now a lot of parents are very aware of croup as a diagnosis. A lot of them will come in and they know exactly it's a barking cough. I think my child has croup. They may have a hoarse voice, stridor, a bit of a low-grade fever, increased work of breathing, but obviously that's not very specific to this. You see that a lot. Most cases can be managed at home with fluids and rest. These cases, again, important to speak with the parent or carer, safety net advice, when do they need to come in, what are they looking out for, and as well as a bit of reassurance. It's very scary for a parent or carer who thinks their child may be sort of struggling to breathe and they're hearing this cough and they're distressed because they're not sleeping. So they need a bit of reassurance of sort of that their child is okay. Here's what you can do if XYZ happens. Here's when I'd want you to bring them into hospital. Here's when you need to get more help. So as I've mentioned, oral dexamethasone, a single dose usually, it can be repeated, but normally that is very, very effective. You'll find some of you may see in GP practice, some GP practices do give this. Others, they will phone across to the local sort of paediatric department or paediatric A&E, and essentially the child will sit with their parent in the kind of waiting area or a quiet room, be given their dexamethasone, and they'll just sit and wait, or they'll sit and play with toys. And then once we see that they've improved and they're okay, then they'll go home. That's very trust dependent. That might even be sort of GP dependent on what people are comfortable with doing. But often there is that option if we need to. So now this one, I want you to remember as the emergency. You always want to be thinking about epiglottitis. You want to remember this one because it's a life-threatening emergency. Within a very short amount of time, there can be so much swelling that the airway is completely obscured, and you could be in sort of big trouble trying to help this child. In general, sort of be suspicious in children who haven't been vaccinated. Cases are now reduced, and this is due to the vaccination programs in children. In any child that's presenting with fever, sore throat, difficulty swallowing, and sort of sitting forward drooling, is kind of the pediatric equivalent of the tripoding position. They're sort of leaning forward. They're really trying to catch their breath, but they're drooling because that airway is closing. You really want to think about epiglottitis. Okay. Does anyone know what this is showing, what this is? Or any ideas you have around it? Yeah, so all correct, basically. So it's sometimes known as the thumb sign, the thumbprint sign, and that's a soft tissue shadow, and that's caused by that edema and swollen epiglottis. In practice, though, you're probably not going to see this because, again, in the chat, in practice, how would you go about investigating and managing epiglottitis? Just, again, 1 or 2 words or whatever you know already. Yeah, perfect. Here we go. Emily, that's essentially ideal. Don't examine them. Very, very calmly get someone with those senior airway skills, anaesthetics, ENT surgeons as well. Do not try and examine them. Remember that in children, especially the younger they are, any kind of examination is distressing. So when you're thinking, oh, I'm just going to ask them to open their mouth, or I'm just going to put my stethoscope on them, for a lot of children, that's distressing. And that sort of distress could be enough to prompt that airway to close. Some general advice is have them sit on a parent or carer's lap. You can get the high flow oxygen just somewhere near their face. Don't try and put it on their face, just somewhere sort of near them. And again, spelling mistakes, sorry, that should say calmly contact ENT and anaesthetics, and start to think more about the logistic things. How are you going to transfer to theatre while keeping them calm? What does that look like? If the child's happy playing with toys, you don't try and take those toys away. Those toys are coming with you and they can be dealt with later. And then one of the most important sequelae to be aware of is apnea, and that is what causes babies to die. So important to not try and examine these children and just get help. Even if you got help, senior anaesthetist came, ENT came, and they said, it isn't this, it's not epiglottitis, fine. That's better than if you've gone, oh, I'm not sure, but I think it could be this. You spent time examining, the child's now upset and crying, and their airway starts closing. Okay, so whooping cough. Again, upper respiratory. Normally starts with mild coryzal symptoms. You're kind of seeing a bit of a trend now, a fever, but the more severe coughing episodes will start after a week and sometimes even longer. And you normally have this loud inspiratory sort of whooping noise that's present when coughing ends. Quite often these coughing bouts are severe and will continue until the child is completely out of breath, and that's why you get that inspiratory noise as well, because they're really having to try and catch their breath after. It's also possible, and not massively uncommon, for children to cough so hard that they either faint or develop a pneumothorax as well, again to be aware of. And important for the UK MLA, because one of the things they want you to know about is notifiable diseases. This is one of those. Again, there's a note there about antibiotics. I wouldn't worry too much about it, but you could just be aware that, as with a lot of notifiable diseases, prophylactic antibiotics can be given to close contacts, especially if they're vulnerable. And also to warn parents mostly that this is sometimes known as the 100-day cough. Often you're expecting symptoms to resolve in around 8 weeks, but there is the potential for a longer duration, and that can be completely normal. Okay, so we're moving on now to one of our last topics. We're going to look at cystic fibrosis. So I'm going to put a poll up now. So we're going to look at cystic fibrosis. So what is the most common CTFR gene mutation in cystic fibrosis? Just answer off the top of your head. Try not to look it up if you don't know. Just give it your best. Great. Okay, so we've got a few mix, but most saying the delta F508, which is a class 2 mutation. 88% of the mutations are class 2. And these class 2 ones, probably the most important one to be aware of, is where the protein, the CTFR protein, does get created, but it misfolds, and this stops it from being able to move up to the cell surface. So important to know, autosomal recessive, you're sort of looking at one of these mutations, probably be aware of the most common one. Don't worry too much about the others, because that would be very mean of them to ask. Sort of key things to think about is the thick pancreatic and biliary secretions, low volume thick airway secretions, and the congenital absence of the vas deferens are important to know about. So in terms of symptoms, you have a chronic cough, you may have the thick sputum production, recurrent infections, steatorrhea, abdo pain and bloating. You do also, it sounds like a bit of a textbook thing, but you do get parents that say that when they kiss their baby, they taste salty, and you will also see faltering growth as well. So then signs then is low weight or height on growth charts. So when you're plotting those growth charts, important to look at. They also get nasal polyps, finger clubbing, crackles and wheeze, and some abdominal distension. So diagnosis, often picked up with the newborn blood spot test. Sweat test is the gold standard for diagnosis. There can be genetic testing for the CTFR gene during pregnancy with amniocentesis or CVS. And just a bit of a bonus question, just list any you know in the chat of what else is screened for on the newborn blood spot test. I'll just give it a couple of seconds for a few more. Okay, yeah, so a lot of you getting the most important ones, and Paul, great with day 5 as well. So ideally day 5 after birth, day 8 at the absolute latest. Don't stress about memorizing all of these. Know some of the main ones: sickle cell, CF, the hypothyroidism, PKU, probably the most important ones, those first few. And then if you could just recognize the names of the other ones, you'd be doing great. Important with CF is thinking about infections. You probably know, 1 from studying medicine, but 2 from watching anything on TV involving CF patients, that we're talking a lot about these colonizers. The key ones that you should be aware of are Staph aureus and Pseudomonas. Pseudomonas being that one that is very, very difficult to get rid of. It often becomes resistant to multiple antibiotics. And those patients, unfortunately, do have an increased morbidity and mortality just because we really struggle to treat them. So your general CF management, chest physio several times a day. You'll find that both patients, parents, and carers become absolute experts. They're dealing with this from very, very young age. They know what they're doing. They often know way more than we do. And actually, when these patients become admitted into hospital for an infection or something else, actually they will be the ones telling you, no, I need to do this, or no, my child needs to do this. High calorie diets, Creon, just be aware of it, don't worry too much. Prophylactic antibiotics can be used. Bronchodilators, again, we're just thinking about sort of what's happening with the airway, what's causing these symptoms, and how we can treat individual symptoms. The same with these sort of nebulizers as well. The vaccination program is very, very important because we want to try and limit the amount of infections being picked up. And then monitoring and screening. So diabetes, osteoporosis, vitamin D deficiency, and liver failure. And then just a little bit about complications. So 90% of CF patients will have pancreatic insufficiency. 50% will have CF-related diabetes and need insulin. 30% liver disease. And then the absent vas deferens causes infertility. Okay. So we're going to finish on an SBA. Rather than me read it out, I'll give you a minute to read it. Then I'll put up the poll with the answers and we'll go through. If anyone's feeling brave as well, it would be great if you could put maybe a couple of your reasonings for an answer or why you've excluded something in the chat as well. Just give a few more seconds for any last answers. Okay, so we had a range of answers. I think 75% of you got the correct answer, so well done. But also this is one of those tricky ones that shows you that sort of SBAs are what you need to practice, because within the STEM there are things that point you to probably each one of these diagnoses as well. So just to pick up on what's in the chat, so salbutamol not appropriate, needs dexamethasone. Yeah. Cough and coryzal symptoms and failure to respond to a SABA is croup. Correct. SATs wouldn't improve with an inhaled foreign body after salbutamol. That is also correct. So that does lead to that. So then if we break it down, the lack of wheeze, so it's being careful with these SBAs, and it's quite sneaky, just the wording. Noisy breathing doesn't mean wheeze necessarily, and the little improvement makes the sort of viral induced wheeze unlikely. So just remembering that viral induced wheeze, asthma likely to improve with salbutamol. We'll come back to croup. It's unlikely asthma, again, very similar to viral induced wheeze, that lack of wheezing, lack of symptom reversal. And again, just remembering with paediatrics, asthma, this is the first presentation, we're not likely to slap a diagnosis of asthma on it at this stage. Inhaled foreign body, be aware of, sort of what was said in the chat is absolutely correct and was something that I thought of with this question as well. Again, this is more a sort of a UKMLA thing, med school exam thing to be aware of. It's overnight, no mention of playing with toys. It's one of those ones that you can rule out on those grounds. Epiglottitis, interestingly, no one went for, but it should be a main differential as well. However, the thing that's pointing you away from that is that symptom onset. Symptoms sort of developing over a few hours with no preceding symptoms would be more epiglottitis. So then that takes us to our answer. So croup, likely that this is a bit of a secondary infection. We spoke about the child being a bit unwell beforehand. That inflammation of the upper airways leads to that partial obstruction. That's what causes that noisy breathing. So that's an upper airway sound. That difficulty in breathing, coryzal symptoms, the barking cough. So that's all I have for today. Make sure you fill out the feedback form, because that means that you'll get a certificate, and that also gives me a chance to sort of adjust for future sessions. My email address is there. It will be on the slides that are given to you, but equally you can take a picture, email me any questions you have at any point. I'll try and get back to you sort of as quickly as I can. Just for your information as well, all of these slides are sent through a paediatric consultant as well, so he does review them. So if there's any questions I can't answer, I can ask him for you. And make sure you join other Mind the Bleep sessions, and I'll see you at the next one. Thank you for attending, and Happy New Year, everyone.